Maitreyee, one of the mentors of StudyMRCOG, and I welcome you to the KickStart series. And let's have a brief discussion and understanding about the various vital points about the topic on vitamins. The objectives for this session, where we shall be seeing through the classification of vitamins, various coenzyme forms of vitamins, the biochemical functions and deficiency manifestations of all the vitamins. So the vitamins we can classify as fat soluble and water soluble vitamins, fat soluble being A, D, E, K. So these fat soluble vitamins, so they are soluble in fat but not soluble in water, and they can be stored in the liver and they are not so excreted, and their deficiency manifestations will take a longer time to present with because there is a good storage in the liver, and because there is a good storage they can go for hypervitaminosis. To contrast to that, water soluble vitamins, they are not soluble in fat but soluble in water, and they have got a simple absorption mechanisms, and they are not stored in the body, and they can easily manifest with the deficiency manifestations. So the toxicity is very unlikely. So because of this, the requirement is on day-to-day basis. Now we shall take care of the fat soluble vitamins, that is A, D, E, K. To start with vitamin A. So vitamin A, the various compounds of vitamin A are called retinoids. So that is an aldehyde form, an alcoholic form, or an acidic form. Retinol, retinol, and retinoic acid. So the pro form of this fat soluble vitamin is beta carotene, which is derived from plant, and the active form we call it as vitamin A, which is there in the animals. So now this vitamin, when we take it in the diet, that is in the form of beta carotene. So this beta carotene, they will get converted to the aldehyde form and the alcohol form, and the alcohol form will get conjugated with the fatty acid, and that will form retinyl esters. So this will go to chylomicrons, and that will be deposited in the liver, and whenever it is required by the various target tissues like retina or other target tissues, the retinol binding protein will help in transportation of retinol, which is stored in the liver, and it will take care to help in various target mechanisms. Now, what are the functions of vitamin A? So vision, it is required for vision. So which form of vitamin A is required? It is the aldehyde form is required. For growth and cellular differentiation, it is the retinoic acid form. For reproductive system, it is the alcoholic form of retinol, that is which is needed. And to take care of all the antioxidant properties, it is beta carotene. And for expressing the genes, the genetic expression is because of retinoic acid. The glycoprotein synthesis is because of the retinol, and proteoglycan synthesis because of retinoic acid. Now this vitamin, which is a very important vitamin for vision, so George Wald who described this one, so Wald's visual cycle. So what happens is that when the light strikes to our eye, retina, there is a photoisomerization which happens in our retina, and it will generate a nerve impulse. So this nerve impulse, what will happen, will help us to clearly identify the color, the depth, and all these things, and it will help us to see through even the dark times, the dark vision. And what exactly happens in this photoexcitation process? So there is a visual pigment in the retina which is called as rhodopsin, made up of the cis retinol and the opsin. So this photoexcitation which happens will break down the rhodopsin to release opsin and all transretinol. So this transretinol will go to blood and liver. It is getting converted to the transformed to cis form, and it is back to epithelium, and it will form the conjugated protein called as rhodopsin. So this whole time is taken for the retina to develop, that is especially in the rods to develop. So this is the dark adaptation time. And when does the nerve signal which is excited to create a image in the brain, when does it stop, and when does from one object to another object our brains can start screening it out. So there is a signal which is required to stop that excited signal. So that is, the signals are terminated by phosphorylating the rhodopsin pigment. So the enzyme is rhodopsin kinase, and there is an inhibitory protein called as beta-arrestin. So it binds to this rhodopsin which is phosphorylated, and the signals are terminated. Now the rods can fix on the another object. So it continuously happens in a very fast manner. So we can easily screen through and check, have a very good vision. So what is dark adaptation time? The bright light, when it strikes the retina, it will deplete, it will cause bleaching of the rhodopsin. So the stores get exhausted, and the person, when they enter into the dark space, so they require some time to see through the whole dark room. So that is the dark adaptation time. So what happens in that time frame? So there is a resynthesis and the vision gets improved. So when the person is having vitamin A deficiency, this dark adaptation time will be increased. Now, is it only for the vision? No, it is required also for cellular division. It is required for differentiation and helping in the gene expression. And it takes care of the epithelial tissues, and retinoic acid will prevent the keratin synthesis. It also helps in glycoprotein and mucopolysaccharide synthesis. It is required to take care of our immune system. It's also required for cholesterol synthesis, and we should never forget about the beta carotene. So they are acting as a very good antioxidants. What are the deficiency manifestations of vitamin A? The primary presentation will be night blindness or nyctalopia. Then it can go for the drying of the eyes, that is xerophthalmia, the conjunctiva, sclera, everything becomes dry. Then there will be a triangular whitish opacity development in the lateral part of the eye, so that is called as Bitot spot. And then keratomalacia, where it is the final phase where the ulceration of the cornea can happen. So these are the eye symptoms, whereas in the other areas, the skin and the mucosal region, so there can be lesions which can be seen. And because it is required for mucopolysaccharides, the growth manifestations, there can be retarded growth, there can be decreased immunity, because it is vitamin A is required for the glycoproteins. So here in this image, you can see the Bitot spot, so well seen over there. So we discussed about how this vitamin A will help in the growth. Also, it helps in bone remodeling. Then in the reproduction, so it prevents the degeneration of the germinal epithelium. So if there is a deficiency, then it can cause the whole defect here, over here. And the skin can become dry if the vitamin A deficiency is there. Skin can become dry. It can present with the eruptions and follicular hyperkeratosis. So vitamin A is not only required for vision, but it is also required for the growth, it is required for the reproduction, it is required for other systems as well. And if the vitamin A deficiency, the urinary tract, respiratory, GI tracts, the epithelial cells can be affected by that one. So vitamin A deficiency, these are the spectrum of presentations. So hypervitaminism is also injurious. So excess intake and storage can cause acute or chronic toxicity. Acute toxicity with the nausea, vomiting, headache, irritability. Toxicity chronically, if it is seen over a longer time, so can present with the hepatomegaly, tenderness and swelling of the bone, loss of hair. What is hypercarotenemia? Where there is, if the person has excessively consumed the green leafy stuff, the foods which is rich in carotenoids, they can present with the yellowish coloration. We should be careful that it is only the skin which is getting discolored, not the sclera. So this is about the hypercarotenemia, so excess consumption of vitamin A. Well, we shall now see about the next vitamin, vitamin E. So this is another fat-soluble vitamin. There are 8 naturally occurring compounds are there. Alpha tocopherol is about the highest biological activity, and since it is a fat-soluble vitamin, it is taking care of the plasma membrane. So it is also called as, addressed as lipid phase antioxidant. So what are the important functions of this? Only one thing to remember: it's a powerful natural antioxidant, lipid phase antioxidant, and it breaks the sequence of reactions which happens in oxidation reactions. So it is called as chain breaking antioxidants, and it because of this prevention of the lipid peroxidation, it will protect from lysis of the red blood cells, delays the aging, and it takes care of the prevention of atherosclerosis. So this vitamin E acts as an antioxidant along with the help of selenium. So if you see this plasma membrane, which is a broken, the edge, so there is a the plasma membrane is made up of PUFAs. So the R superscript dot, it is a free radical. So it can attack this free radical, it can attack the PUFA. So what happens is PUFA becomes now a free radical. So the sequence of reactions can continuously go on. So the sequence of reactions can continue and it causes a breach in the membrane. So to avoid that, the tocopherol will come into the picture and it will scavenge this free radical, and then the tocopherol, now it has become a free radical. So now this is taken care by vitamin C. So vitamin C is a water soluble antioxidants. Along with that, the glutathione, which will help in the free radical scavenging. So it will take care of it, and the a good fresh vitamin E is synthesized, and again it can tackle the any other free radicals left out. So in this way, the vitamin E is taking care of our plasma membrane, whereas outside the plasma membrane, it is the vitamin C which is helping it. This PUFA, the polyunsaturated fatty acids, which is there in the plasma membrane, can also be attacked by another free radical, that is superoxide. So how does the body has got a mechanism to control this action? Superoxide dismutase is an antioxidant enzyme. Along with that, there is a catalase which can also prevent or scavenge the free radicals. So the superoxide molecule can be converted to hydrogen peroxide. Hydrogen peroxide becomes a non-toxic water molecule. So with the action of superoxide dismutase and catalase, so the actions are taken care. Now we should also appreciate the presence of selenium, which is there in the glutathione peroxidase, as you can see. So this is the cofactor present in the glutathione peroxidase. Now, so selenium and vitamin E, they act synergistically to take care of this, the free radical scavenging mechanism. So that's about the various antioxidants, nature of vitamins, and some of the enzymes we learned in the slide. Now let us see about the effects of other vitamin. Anything is required. So this excess of vitamin can cause toxicity, and the deficiencies can be seen if it is like vitamin E deficiency. It can present with the bleeding tendencies. It can sorry, that's about the vitamin K. Sorry, we are talking about vitamin E here. So the vitamin E, so if there is a deficiency, it can go to muscular weakness, neurological problems, ataxia, retinopathy, peripheral neuropathy, myopathies can be seen. So deficiency is also bad, hypervitaminosis is also bad. So hypervitaminosis of E will lead to bleeding like tendencies. Now vitamin K, it's another fat soluble vitamin which has got a coenzyme like action. So there are various forms, K1, K2 and K3. K1 being the phyloquinone present in the plants. K2 is menaquinone, which is present in the intestinal bacteria, and also it is found in the animals. It is the menaquinone. And K3 is menadione. It is a synthetic form, which is the injectable forms which is used in the hospitals. It is the K3 form. So this vitamin K is required for clotting mechanism. So it is an essential cofactor for the clotting mechanism. So what is the role of vitamin K? As we learned, it is required for coagulation. So which factors are dependent on vitamin K? It is factor 2, 7, 9 and 10. So these clotting factors, when they are synthesized, so they are synthesized as zymogens, that is the inactive form. So they requires the activation. So the activation, how does it happen? It is the glutamic acid residues present in these clotting factors will undergo carboxylation. That is, addition of the COO group will happen on the glutamic acid residues. So is it only the clotting factors? No, there is another protein in the bone called as osteocalcin. Even that can undergo gamma carboxylation. So this will take care of the clotting mechanisms as well as strengthening of the bones. So the clotting factor and the calcium complex binds to the phospholipids on the membrane, and it helps in the the platelet action to continue with. So you can see in this image the clotting factor, the glutamic acid residue is undergone after the gamma carboxylation has received a carboxyl group added to it. So the clotting factor is activated. Now the vitamin K antagonistic, so that is dicomarol and warfarin, so they will act at this point. So they will inhibit and it will not allow for the activation of the zymogens, that is clotting factor 2, 7, 9 and 10. So vitamin K will help in good absorption of the calcium at the bone. So because of the osteocalcin, so osteocalcin undergoes gamma carboxylation, then it binds tightly to the hydroxyapatite crystals of the bone. So this will enhance further degree of gamma carboxylation. So osteocalcin also contains hydroxyproline. So it is dependent on both vitamin K and vitamin C. Okay, so what are the causes for the vitamin K deficiency? So faulty absorption or prolonged antibiotic therapy or some GI causes where it will not allow for good absorption of vitamin K. What are the manifestations? They can present with the hemorrhagic disease of newborn, and in adults it can present with the ecchymotic patches, mucous membrane will present with the hemorrhage, post-traumatic bleeding, internal bleeding can happen, and the biochemical parameters which are affected are prothrombin time and the clotting time. So there will be prolongation of the prothrombin time because prothrombin is the factor required for clotting mechanism. So there will be delay in the prothrombin time. So which is the antagonistic? We have learned dicomarol and warfarin. They competitively inhibit the gamma carboxylation. Now hypervitaminosis K so can also happen. So excess intake of vitamin K rarely happens. If it happens, it can promote thrombogenesis, hemolysis. There is an increased risk for jaundice and kernicterus and brain damage can happen. We'll see about the next vitamin, that is sunshine vitamin, also called as vitamin D. So it's a steroidal molecule, and the different forms of vitamin D2 and D3. D2 is from the plant derived ergocalciferol. D3 is cholecalciferol. Now when the sunlight, that is UV light, strikes our skin, there is a 7-dehydrocholesterol which is present in our Malpighian liver. So it will undergo activation. So the pro form of vitamin 7-dehydrocholesterol, when it is got a sunlight exposed, it will get converted to cholecalciferol, that is the vitamin D3. So how does this activation of vitamin D help in good absorption of calcium? So sunlight, we learned that 7-dehydrocholesterol is converted to vitamin D3 cholecalciferol. Now this has to undergo further activation. So which the first step will be in the liver, 25-hydroxylase enzyme will convert it into 25-hydroxy vitamin D3. Now this will go to the kidney where there is a 1-alpha hydroxylase. So hydroxylation will happen at the first position to generate the calcitriol or 1,25-dihydroxy vitamin D3. So this 1-alpha hydroxylase is a key enzyme. So it is under the influence of parathyroid hormone, and if there is excess of calcium or phosphorus, so the feedback signals will reach out to this enzyme and it will control the activation of vitamin D. So what is the action of vitamin D? It will help in absorption of calcium. So calbindin is a protein which is synthesized, so that will help in absorption of the calcium. The biochemical effects are seen on the intestinal villi, the bone cells and the kidneys. So in the intestines, it will help in calcium and phosphorus absorption, and then in the bones, it will help in mineralization of the bones, primarily mineralization of the bones when there is adequate supply of calcium is there. So the calcium values in the blood which is maintained is in 9 to 11 milligram per deciliter. So if the person is in hypocalcemic, then the bones can undergo demineralization. So it is taking care of blastic and clastic activity both. So during the the adequate healthy state, the blast will synthesize ALP, which increases the concentration of the phosphate and will help in bone strength. About on the kidneys, it increases the reabsorption of calcium and phosphorus from the kidneys. So ultimately the plasma calcium levels are taken care all the time, either from absorption of intestine or from the reabsorption from the kidney, or it is the bone turnover. So deficiencies in the children, it is rickets, osteomalacia in adults. So when we check, how do we evaluate the bones? For look for serum calcium, albumin, phosphorus, alkaline phosphatase, parathyroid hormone, and vitamin D. So if the dose is above 1500 units per day for long it is consumed, it can go for hypervitaminosis, presenting with weakness, polyuria, intense thirst, difficulty in speaking, hypertension, weight loss, and it can go for even calcinosis in the various tissues. So that's about the fat soluble vitamins A, D, E, and K. Now we'll see about the water soluble vitamins, which is B and C. So water soluble vitamins, so there are various forms. We will take one by one the various forms of water soluble vitamin. So first one is B1 thiamine. The coenzyme form, it is called as thiamine pyrophosphate. It is very richly found in the outer coatings of the grains like rice, wheat. What is the biochemical role? It is required for three enzymes to remember. Pyruvate dehydrogenase. This is an enzyme which is required for oxidative decarboxylation of pyruvate to acetyl-CoA. Alpha ketoglutarate dehydrogenase, which is the enzyme of TCA cycle, and transketolase, which is an enzyme of HMP pathway. So if you want to evaluate the vitamin B1, look for transketolase activity, that is in the erythrocytes. So it will be low. The deficiency manifestations, beriberi. So there are wet beriberi, dry beriberi, infantile beriberi, where it is seen in the infants with presenting with restlessness and sleeplessness. Wet because of the CVS manifestations of predominant. Dry, it is the CNS manifestations of predominant. Wernicke-Korsakoff syndrome, they present with ophthalmoplegia, nystagmus, ataxia, psychosis. So there are other manifestations which can present with acidosis also. We'll see about the next vitamin B2, riboflavin. Which are the coenzymes of this riboflavin? It is FMN, which is required for the conversion of L-amino acid to L-amino acid, and also it is required for electron transport chain. So this is about the FMN action. And FAD, so there are various FAD dependent reactions, as you can see, that is alpha ketoglutarate to succinyl-CoA, pyruvate to acetyl-CoA, xanthine to uric acid. So where the FAD dependent reactions. Now this vitamin D is required for, if it is not supplied in the diet, it can go for deficiency manifestations. So they can go for angular stomatitis, chelosis, glossitis, even vascularization of cornea can happen. So vitamin D3, yeah, vitamin D3 is also called as niacin, NAD, or the coenzymes being NAD and NADP, nicotinamide adenine dinucleotide, nicotinamide adenine dinucleotide phosphates. So various NAD dependent reactions, as you can see, and NADP dependent reactions. So where the NAD comes and helps in conversion of the main catabolic reactions like lactate dehydrogenase, glutamate dehydrogenase, or NADP dependent enzymes are glutathione reductase. Now, similarly, NADPH dependent reactions enzymes are HMG-CoA reductase. This is an enzyme which is required for cholesterol synthesis, regeneration of hemoglobin, generation of the active form of folic acid, that is tetrahydrofolic acid. So these are some of the examples for NADPH dependent reactions. So deficiency of this niacin will present with pellagra. There is diarrhea, dementia, and dermatitis. Anything which hinders the availability of vitamin B3 can present with the niacin deficiency, that is pellagra. So the isoniazid, the antitubercular drug, will inhibit pyridoxal phosphate. This is vitamin B6. B6 is required for niacin activation, and niacin is synthesized even from tryptophan. So tryptophan deficiency can cause, or excess of tryptophan consumption for production of serotonin, which is a mechanism to, the tryptophan required for serotonin. Also carcinoid syndrome, there is excess of serotonin production, so there is deficiency of niacin that can also pose with the pellagra like features. Moving with the vitamin B6 pyridoxine, its coenzyme is pyridoxal phosphate, PLP. So it is mainly required for amino acid metabolisms like transamination reaction, decarboxylation reactions. Some of the examples for decarboxylated products being GABA, then from histidine to histamine formation, dopamine, serotonin. So these are all the decarboxylated carboxylated products, and generation of the taurine. And it is also required for sulfur containing amino acid metabolism, that is the methionine metabolism, cysteine metabolism. It is also required for heme synthesis. So vitamin B6 is required for that is the heme synthesis. And we had discussed about niacin. Niacin production is dependent on B6, also required for glycogenolysis. So deficiency of this vitamin B6 presents more with the neurological manifestations, where because of the deficiency of various decarboxylated products, so with the presenting with neuritis. Then dermatological manifestations is because of pellagra-like features. Hematological manifestations because the heme synthesis is affected, and it can be seen presenting with seizures because GABA is not synthesized in the absence of vitamin B6. Next, vitamin biotin. It is the coenzyme required for carboxylation reaction. So the three enzymes, remember, acetyl-CoA carboxylase, converting acetyl-CoA to malonyl-CoA. So this is the first step in the fatty acid synthesis. Pyruvate carboxylase, pyruvate to oxaloacetate. So where there is a gluconeogenesis is happening, this is another enzyme for gluconeogenesis. And this is the propenyl-CoA carboxylase, propenyl-CoA to methyl-malonyl-CoA. So this is an odd chain fatty acid which also is dependent on the vitamin biotin. So these are the three enzymes of dependent on biotin. So biotin can be antagonized by the protein called as avidin, which is present in egg white. So if egg is consumed uncooked, so this avidin which is there in abundant, so that what it will do, it will capture and seize 4 molecules of biotin, not allowing for any biochemical functional requirement. So that person can go into vitamin biotin deficiency. So when we cook the egg, then this avidin is destroyed and it becomes easy for digestion for various mechanisms availability. The deficiency of this biotin can present with dermatitis, glossitis, anorexia, hallucination, muscle pain. So we should remember that prolonged antimicrobial drugs can lead to the deficiency manifestations. So what are the biochemical functions of vitamin C? So it is acting as a reducing agent required for dopamine synthesis. It is required for adrenaline hormone synthesis, so dopamine to non-adrenaline, and then it is required for bile acid formation. It is required for collagen maturation, so hydroxyproline and hydroxylysine formation, and then it is also required for the conversion of tyrosine metabolism, that is to form homogenesic acid, and it is required for folate metabolism. So folic acid reductase is an enzyme which is dependent on vitamin C. So folic acid to tetrahydrofolic acid, which is the active form of vitamin, that is folic acid. So that is the formation of active form of folic acid is dependent on vitamin C. And then methemoglobin, when it is formed when we are exposed to the vehicular exhaust or carbon, the vehicular exhaust and all. So it will convert hemoglobin to methemoglobin. So methemoglobin has got high oxygen affinity. It will cause the decreased availability of oxygen to the tissue. So we need to constantly get back hemoglobin, and vitamin C helps in that one. And it's also required for good absorption of iron and also required for steroid synthesis. Never forget about the antioxidant role of vitamin C. So the deficiency of this vitamin can go for scurvy, presenting with various hemorrhagic tendencies, weakness, and swollen gums, joints, loose teeth, susceptible for infection, delayed wound healing. They can present with the fragility of bones, and porosis of the bones can be seen. So that's about vitamin C. Moving ahead with the vitamin folic acid. So folium, that is the vitamin which is mostly seen in the green leafy vegetables. So this folic acid contains, structurally it contains pyridine ring and para-aminobenzoic acid and glutamate. So this folic acid, the coenzyme forms, it can be present in different forms. So, and it is the folic acid, it is the only action of the folic acid, if I have to say, it is a 1 carbon group carrier for various reactions. So which are those 1 carbon groups? Formyl, formamino, methinyl, methylene, hydroxymethyl, and methyl groups. So as you can see here, there are various 1-carbon donors and that will be accepted by tetrahydrofolic acid. Now folic acid, after tetrahydrofolic acid, after accepting this the 1-carbon groups, it will become formyl tetrahydrofolic acid, hydroxymethyl tetrahydrofolic acid, methyl tetrahydrofolic acid. So what are the products formed because of this 1-carbon carriers? Purine, you get C2 of purine, C8 of purine, formation of DTMP, from DUMP to DTMP, and it is required for the that is methylated tetrahydrofolic acid is required for the various methylated compound formation like choline, creatine, epinephrine, and even methionine. So these are the functions of vitamin folic acid. What are the causes for deficiency? Pregnancy, defective absorption, any anticonvulsant drugs, hemolytic anemia, dietary deficiency per se, or it is the vitamin B12 posing for folic acid functional deficiencies. So the deficiency manifestations, how can we see? The most commonly in pregnant ladies, they are got a high risk of developing neural tube defects. And why folic acid supplementation is given? So as you can see in this image, the folic acid is required for conversion of DUMP to DTMP, and this DTMP is required for DNA synthesis. So during the organogenesis, if DTMP is not available, then the neural tube defects can be seen. That's the reason where folic acid supplementations are given. Now what is macrocytic anemia? So if this vitamin folic acid is not available, nuclear maturation will not happen, whereas the cytosolic maturation will continue to happen, presenting with macrocytic anemic picture. And why? There will be increased blood levels of homocysteine because the homocysteine to methionine conversion is affected. In cases where vitamin B12 deficiency is there, the folic acid cannot be converted to tetrahydrofolic acid. So methyl group cannot be transferred to cobalamin. Okay, so this methyl group naturally should be have transferred to homocysteine to convert it into methionine. Now this factor is affected, B12 is not available, so the folic acid is like having a folate trap like mechanism. It is trapped as methyl tetrahydrofolate trap. Okay, so that is the reason. So this, when there is folic acid is not available, the homocysteine levels are obviously elevated, presenting with homocysteinemia and the homocystinuria. Okay, so that's about the deficiency manifestations. So even some of the drugs like all these things, pyrimethamine, trimethoprim, methotrexate, so they can go with the folate antagonistic like presentations. They are inhibiting the various enzymes for folic acid activation. So methotrexate, it inhibits dihydrofolate reductase inhibitor. So aminopterin inhibits the folate reductase enzyme. So these are the reasons, some of the drugs which can inhibit the folic acid availability. So pharmacologically, so there are some folic acid analogs like folinic acid, leucovorin synthetic compound, so which are in market available. So with the folic acid, we shall move for vitamin B12. That's the last vitamin. So it's also called as extrinsic factor of Castle, or it is also called as anti-pernicious anemia factor. Also, it is called as cobalamin. It contains cobalt in the structure. So there are different forms of vitamin B12. If it contains cyanide in the structure, cyanocobalamin, the oral preparation forms. Hydroxyl groups represent hydroxycobalamin injectable preparation. Adenosylcobalamin, which is a storage form. Okay, and then methylcobalamin, it is the major form which is there in the blood and the cytoplasm. It has got a functional role, so it is the coenzyme. Now why it is called extrinsic factor? So when we consume in the diet, so there is a protein which is synthesized on the gastric parietal cells, intrinsic factor. So they form a conjugate in the intestine, and that conjugated complex will be absorbed at the ileal cells. So this if the gastric parietal cells are not available, or if this ileum is for any reason, medical surgical reason is affected, the vitamin B12 deficiency can be seen. So why it is called anti-pernicious anemia? So in pernicious anemia, there is autoantibodies targeted against parietal cells. So that is the way it is, also referred to as anti-pernicious anemia factor. Now, vegans have got a high risk of developing B12 deficiency because B12 is only an animal source. Now, this is an exception. All the fat-soluble vitamins are stored in the body, whereas water-soluble vitamins are not stored. So here is an exception. B12 is stored in the liver, and just 2 milligrams is quite sufficient for 2 to 3 years. So how about the vegetarian people to take care? It is a good amount of vitamin B12 is available in curds. So what are the functional role of vitamin B12? There are two enzymes to remember: methyl malonyl CoA isomerase, which converts the short chain fatty acid propionyl CoA to methyl malonyl CoA and then to succinyl CoA. So this is one reaction, and homocysteine to methionine formation, it's another reaction which we have already learned. So the deficiency manifestations, if B12 is deficient, it will also cause folic acid deficiency, functional deficiency. So when the therapy is given, we have to also make sure that folic acid and B12 are given hand in hand. Okay, then megaloblastic anemia can be seen, increased levels of homocysteine, demyelination, the degeneration of the combined degeneration of the cords can be seen, or there can be hydria. How do we assess B12 deficiency? Look for vitamin B12 serum levels or check for methyl malonic acid. So methyl malonic acid will get converted to succinyl CoA, which won't happen here in the deficiency cases. So it will be excreted in the urine, or look for the peripheral smears. Look for serum homocysteine levels, which will be elevated. So these are some of the functions of the and the deficiency manifestation. So what did we cover so far? So we looked for the vitamins, coenzymes, functions, and deficiency manifestations. So I thank you very much for your time and attention. And we study MEDIC family. We cater to a lot of programs over here, as you can see. So do check out our library, do enroll and look out for what is best suitable for you. So wishing you all the best. Thank you. Bye-bye.